सर आप अगर सिस्टम से लॉगिन होना चाह रहे हैं तो लॉगिन हो जाए सर, अगर वॉल्यूम सेम है।
Yeah, 1 second. It is same because it has not changed much.
Sir, we are good to start.
Okay. So good evening, friends. Welcome to this Tuesday evening critical care sessions from ISCCM Hyderabad chapter and Yashoda group of hospitals. We try to bring some topics of interest for you to have some learning experience. And today we have a topic for which ISCCM National has taken a lead to do something about research limited countries. Sepsis being a major contributor for the mortality in any hospitals across the world, but is more predominant in this part of the world where there is a healthcare facility deprivation. So there are around 50 million sepsis cases where majority of the deaths of 85% happens in the resource limited countries like India. So the guidelines, the literature, the evidences which are coming, majority they come from so-called the high income countries. So ISCCM nation has tried their best to put across a fraternity to look down at the position statements, and that position statement is under the publication. And Dr. Yash happens to be one of those part of that position statement. So we welcome Dr. Yash, who has been the
Thank you, Doctor.
yeah, so he has been a part of convener for the emergency college, is the vice president of ISCCM, and he is a part of Regency Health, if I'm right, in Lucknow at this point of time, heading both emergency and critical care at this point of time. We welcome you, Dr. Yash, and it is a privilege and proud moment for us to have you on board. You are a seasoned senior clinician with a vast experience in the sepsis, and you happen to be a convener for Sepsis Forum of India. So it will probably a day where we will all get exposed to your all wisdom, sir. Welcome you on board.
Thank you, Dr. Venkat. I'd like to thank Yashoda Group and Dr. Venkat in particular for having me for this particular panel discussion. And we look forward to a great interaction from Dr. Venkat and from all other participants. Thank you.
So is my slides clear?
Yeah. Yes, please.
Yeah. So as we actually discussed about, this is a major issue in research limited setting compared to what we talk about in more of high income countries, but majority of data comes from there. We follow the guidelines or maybe the statements from those countries. So we are trying to actually look into what are our challenges here, and probably the position statement, which is going to be published in maybe a next edition, will give us more insights into that. So what I felt, the challenges which I face or we all face in India compared to what happens in those Western countries where the resources are abundant, are the disparity in healthcare availability. See, you will find the healthcare systems in India, which are probably as par with the West or maybe sometimes better. It happens to me, Dr. Yash, that recently I have a friend from Cleveland, Dr. Pius, who has been here looking at our facilities, says it's much better than any facility in that part of the world in United States. So we are proud that we have facilities like that, but in the same time, we do have healthcare systems in the remote of our villages where even a basic sanitary practices has been also limited, and maybe a regular practices of giving an IV fluid has also not been available. So such a disparity in the healthcare system across the length and the breadth of India is a reality. Then we all understand that we do have resource limitations, even though we do have some public infrastructures, but the intensive care unit is limited in many of our countries, and the beds are limited. And that too, now we have seen post-COVID, the ICUs are built in many in public sectors, but the question is, do they manned by adequate trained, skilled manpower? I think we are still lagging along behind that to actually trained manpower manning these ICUs is a question. If you compare the disease burden of sepsis and this morbidity, the burden is equally distributed across, but the severity and the mortality is at around 85% in this part of the low and middle income countries. But what is our problem? Our problem is the disease burden is much higher relative to the ratio of healthcare professionals which we have, or the healthcare facilities or beds we have. So the burden is more here, and relative availability of healthcare professionals or facilities are relatively less. So the ratio is much higher. So we have patient issue, doctor ratio, available bed ratio is much less compared to what we see in that part of the world. Antimicrobial availability, usage, as I don't know, misuse or abuse has created a rise in antimicrobial resistance, which is beyond the control of any of us right now. We have seen a rampant rise of multi-drug resistant antibacteria across these countries in where there is a resource limitations like India. We also see some religious belief, which varies from the part to part, where the practices are different and may still, I believe, varicella has been considered as something which not to be treated with medicines, and there have been maybe the prayers will be done for to cure it. So there are still some religious belief where people still stuck here and there. I'm talking about those remote areas where the religious belief still takes a bigger role. Availability of alternative maybe modalities of healthcare systems, including the all others with no EA to any other alternative medications, but they do play in the practices here. Late presentation because of poverty, before of awareness, because of the reachability, we do see the patients who come to these tertiary care healthcare systems, either a public or a private organization, the presentations is relatively late compared to those of the other countries. Uncontrolled, unmonitored underlying comorbidities. Many of our patients who are diabetic, who have some other illnesses, comorbidities like asthma, COPD, or any other diseases, the follow-up and monitor has been relatively less in this part of the world. Tropical illness adds a lot of challenge in this part. Like you have malaria, we have dengue, we have other arboreal diseases, you have helminths, and you have protozoas, all play a bigger role here in septic patients or in the infection. Living conditions, we do understand the living conditions add at least to these infectious diseases. So the living conditions are a bigger challenge in this part, like when you have poverty, the hygiene, the cleanliness, those all take into a task. Access to clean water, clean air, hygienic restrooms, these all play a major role in India, that we are a different part to manage these cases, even though we may have some common guidelines, but because of all these differences in this part of the world, we may need a probably additional statements to help us, or additional maybe coverage to help. So this was what I actually saw the burden, where you can see a good amount of burden is in the low income countries relative to those are high income countries. And we see around 50 million burden, 15 million cases of the sepsis in a particular year, throughout the year across the globe. But 85% of those mortalities of this sepsis patient, that is 17 million, happens in resource limited countries with low and middle income. So you can see, even though the burden is maybe equal in all, but the majority of the deaths and mortality is confined to low and middle income countries. Again, as I said, geographically, the cause of this sepsis varies. As I said, if you look at India or Southeast Asian subcontinents, you have bacteria, including your melioidosis, meningitis, tuberculosis, tetanus, rabies, dengue, tropical illnesses take a lead. So we have a different set of things which may have a problem with us. And again, very disparity in what we spent on our health. the health expenditures in many of our low and middle income countries is bottom low compared to what happens in high income countries. And again, this was another study in the 2 years back where we see around 213 patients for every 1 lakh population gets at any point of time the sepsis, and you can see the number of ICU units for 1 lakh population is around 17 beds. So this is again a description of how low and middle income countries actually struggle in this disparity. We all now understand that the sepsis is not just about infection. We are talking about that infection when it spreads to the bloodstream or a systemic way and causes multiple organ dysfunction. Then we are talking about sepsis. The rest all were only limited to the infection. So the simple infection, what we understand, the mortality rate probably is close to 0. But when it actually, the severe sepsis turns to a systemic infection leading to organ dysfunction, probably your mortality goes beyond 10 to 30%. So right now, the rest all we have confined to infections where there is no systemic manifestation leading to organ dysfunction as a simple infections. And sepsis has been now defined or being picked up with some of those scores, which has been initially with sepsis 3 guidelines spoke about out of ICU, out of emergency room, in a remote places, in the wards, or in the other healthcare systems without a intensive care unit. With a quick SOFA, we can assess 3 important parameters like altered sensorium, a tachypneic patient with a fast respiratory rate and low systolic blood pressure. Any 2 among them with a suspected infection, we should consider them, they are a sick group of patients, need to transport to a properly monitored, cared area of the hospital or to a healthcare system. But this gone into a toss because of its sensitivity to pick up all the cases of sepsis. So in 2021-22, when surviving sepsis guidelines came, they probably felt QSOFA is not as sensitive. Probably it may predict the outcome. It may predict about the severity. It may predict about the possible deaths and mortality, but it is not as sensitive as the previous course of systemic inflammatory response syndrome or the MUOS, the early warning sign scores, which has been used in the hospitals to pick up. But is it true for us? Is it true for the resource limited countries like India? Maybe this is one of the quickest score where without any lab parameters, in a quick way, I can probably look at 3 things and may actually cohort those group of patients who needs immediate attention. So countries like India, QSOFA may play a role. So discarding it, what happened in the surviving sepsis guideline may not be a sensible option at this point of time, and we may add few more parameters, but QSOFA may consider one of those ways to pick up those sicker cohort in countries like India. The other score which has been proposed in the surviving sepsis guidelines as MUOS, the modified early warning score, which actually adds to your saturation, because after COVID, many of our families, including the remote of the villages, we do now have a pulse oximeter. So saturation can add value. And again, your temperature or other things, the heart rate can also add to this. And you have a very simpler form that the AVPU of your sensorium can give you an ad. So it is believed that the modified early warning score is probably a better score in sensitivity to pick up all the cases of suspected sepsis. When you have a suspected infection with any of these positive scores, then you may consider them to have. So in resource limited countries, both QSOFA and MUOS may play a role. So we will use both of them, whatever is available and comfortable to your place. So the change is we probably will not discard QSOFA as quickly. And coming to the SOFA, again, we know the SOFA needs lab parameters. Lab maybe needing an ABC in them, and maybe both LFTs and RFTs and blood pictures. So this, once the patient is in the intensive care unit, probably maybe a SOFA score can be assessed. But before that, a Q SOFA should be continued to give you the information. And again, we have these things ki lactates or vasopressor requirements. If I have a patient with a Q-SOFA being positive and patient is hypotensive in spite of volume resuscitation, probably I will look at a septic shock, irrespective of lactates are available or not. So I think from sepsis 3, we have seen a different kind of definitions which has been given, and we are happy that now Indian Society of Critical Care Medicine, Asia Pacific Sepsis Alliances are a part of it. So we have a representation from the low and middle income countries with resource limitation, so that hopefully we will contribute our data to them, and maybe you will have a separate section in the same surviving sepsis guidelines in resource limited setting, what all we can do. We all now talk about, it's not just about infection, it is also about dysregulated host response. We see that the same dengue occurs in all the family members. One gets sicker, all the rest all recover within 3-5 days. But one patient go into the multiple organ failures, may be leading to mortality. The same thing we see in we're seeing in influenza or previously COVID. The same virus infects a set of patients, but one or two of them get sicker. So we believed it is not just the same the agent, the bacteria or a virus, but it is the host and environment which also plays a role, which is the rule of it that all the three interaction, host, agent, and the environment creates the atmosphere. In septic patient, we all believed that the dysregulated, very flared host response to any insult of infectious insults creates the havoc. So if we are in that stage where there is a dysregulated havoc of host response, how do we actually monitor them? How do we actually treat them? That has been a part of the recent discussion. So just for a example, we do see that we get patients of young age group with high-grade fever, with chills, rigors from remote parts, with decreased urine output, breathless, altered mental status. From your Q-SOFA or SOFA criteria, you may fit all of them. And you treat them with antimicrobials and doxycycline as a supportive empirical therapy. But you may find them on your peripheral smear next day by your pathology saying you are probably seeing a plasmodium falciform in your peripheral smear. So please add maybe one of those antiparasitic agent to treat. So what I'm trying to say is, in India, it is not always the bacteria. You need to look at where from this patient came, what is the clinical syndrome. Can this be a malaria? Can this be a dengue? Can this be a scrub? Can this be a leptospira? Can this be a malidosis? So it is not always the meropenem or a ticoplanin, but it's sometimes you need to keep a watch of what kind of cohort your patient is, where from he is coming from, what was the typical signs. Is the fever is intermediate in nature and comes with a chills and rigors? He comes from a background where there is still a parasite prevalence is there, or you are in a time where there is a dengue season or a dengue epidemic going on. So you need to keep a watch on all of that, so that it's not always bacteria, but you can sometimes see a parasitemia, viremia, or maybe fungemia in them. So dengue is not uncommon in seasons where we see a very good amount of load of dengue sepsis. And we know this sometimes gets to a state where, in spite of all our efforts, we do lose them in a good number when they are with a multi-organ failure and DAC. So this need to be kept in mind. And I think we need to focus and do a lot of work and research onto the regulation of this flare of immune dysregulation in dengue patient. See, COVID has affected across the globe. So we have seen a lot of studies happening during the COVID. But it's not true for dengue. Dengue has not been evaluated in the same way. Dengue studies has not been. Do I have any magic bullet for the dengue fever? Can I stop this dysregulated immune response in dengue? We don't know. Can any maps be useful for here? We don't know. Can a plasma exchange can be useful for you? There has been a studies with the steroids which has proven to be failed in dengue. So the question is, we have a different problems. Our tropical fevers, our tropical sepsis are different from what we see in West. So we need to invest our time, probably invest our efforts in actually finding out a solution to our pathogens, including dengue. COVID probably we may consider it as a disease of past, but we do see pockets of cases. In the last week, we have seen 7 dengue ARDS patients intubated, prone, all of them initially a multiplex PCR in your respiratory panel picked up and confirmed by a RT-PCR later. And all these patients were having a typical COVID ARDS with the same CT finding, which we have seen in 2020-21. So again, we all know about those dysregulated responses which we have seen. So what we probably try to say is, as a country or as a part, these group, low and middle income countries, including India, have a special problems, maybe have probably a different problem. So these problems need to be addressed. And we all understand septic patients lose their organs, and every hour matters to us. In fact, every minute matters to us. Like what we have the sensitivity for the myocardial infarction, the sensitivity for the stroke or a brain infarct, we don't have a sensitivity for a sepsis. You must be knowing you have a ACS clinical pathway or a stroke code in many of our hospitals. We need to have a sepsis code in many of our hospitals. Now, major tertiary care hospitals in the country, even in India, has started sepsis code. So sepsis has to be given the same kind of priority to make sure that these all can be executed. If not a sepsis code in a remote setups, the awareness of its severity, the early response team has to be created in countries like India. Coming to our bundle in many of our previous pictures, where we actually talk about measuring lactates. But if you look at good percentage of healthcare system, maybe around 80 to 90% of healthcare system, don't have an access to arterial blood gas analysis. And this is the reality. So if I don't have access to arterial blood gas analysis, I don't have any way to actually do it? No, I think in 2021 sepsis surviving guidelines after the Andromeda trial, we now talking about a capillary refill time. Yes, we do have some limitation in that in patients with a darker skin with a higher melanin, but yes, you can use it as a tool to see the capillary refill, and it has been found to be probably non-inferior to our measured lactate. So for all those who actually are not able to access the arterial blood gas, you can use a capillary refill time as an initial marker. And we all understand the window, like your sensorium is a window for your neurological circulation. Your urine output can be a window for your cardiac output. In the same way, skin and your capillary refill can be a window for your peripheral perfusion. And if your capillary refill time is quicker, then it's fine. Your perfusion is still holding on. If it is too slow and it is more than 4 seconds or 6 seconds, probably you need to improve your circulation. So that's one of the points which has been emphasized in recent times. And then the second point is emphasized on obtaining blood culture before administering antimicrobial. Pardon me that we do not have access to blood culture bottles or the culture system in many of the primary or even in district healthcare systems. So just waiting for a cultures to be sampled probably doesn't make a sense. As we said, every minute, every hours kills patient. So if I don't have access to a blood culture or any other culture systems, I probably will not delay to give antimicrobial if I have a sick patient with me. Probably I'll take cultures later. I do understand there is a limitation once I give antibiotic and take culture, but it is true even in the first set. If you take a blood cultures even before antibiotic, your yield may be somewhere between 40 to 60%. It is not greater than that. And so if I have a patient who will get benefited by my early administration of an appropriate antimicrobial, probably I should not wait just because there is our bundle which says you should be taking blood cultures before administering antibiotics. And then coming to your fluid resuscitation. So fluids, we prefer crystalloids, as been given in this chart also. And the crystalloid which has been preferred in most of us is either a ringer lactate or Hartmann solution. It's probably no fancy industry-driven solutions are required. It is simple that a regular ringer lactate will be fine, and maybe initially a liter and half bolus, if I don't have any known problems, should be enough in many of our situation, or should be the initial start of in many of our situation. So that is again, and probably using a broad spectrum antimicrobial, which is again, as I pointed out, you need to look at your geographical location and your patient syndrome, and then probably choose your antibiotic. Maybe I may need ceftriaxone and azithromycin in some of the situation. I may need carbapenems in combination with some doxycycline in some situation. So you choose your probably antimicrobial according to your local need of your patient syndrome, not as for the just an empirically what we probably see in the practice. Then vasopressors, even though noradrenaline has been a preferred vasopressor to start with, if I have a periphery where norepinephrine is not available, and I have an alternative like adrenaline, probably to start with initially till I reach to a place where norepinephrine is available, I can use adrenaline in the same dilutional form to actually keep the BP up till I reach to a place where noradrenaline is available. So, and we do use all these crystalloids and vasopressors. If central line is not available, I can still use a large bore peripheral or a external jugular vein till I get access to them. And that is probably an alternative acceptance in resource limited setting. I don't need to have a rule as a central line or arterial line to actually do all these things. We all understand this vigilance and measuring them. And whenever we have a patient with septic shock, where I have a patient with all those things which I told, along with a hypotension and probably very poor capillary refill, and I can see the patient is demented, there is a decreased urine output, and my capillary refill is very slow. I have a very high mortality. And this is the flow which most of us do, that start. We start with IV fluids, and then vasopressors, then dobutamine, and then again, the important part in this is de-escalate. After your fluids and vasopressors and the dose, stress dose, when those are not able to help you to maintain, we actually use a low dose steroids in the form of 200 milligrams in 24 hours. The important point, I think, even in resource limited setting, this is what is lagging, is we do not de-resuscitate. Once my patient gets better, continuing the IV fluid has been very commonly seen without any indication, and that causing a lot of harm to the patient than benefit. So probably in resource limited setting, de-resuscitation emphasis has to be given, because now we have seen IV fluids has been used more empirically and probably more enthusiastically to manage these cases. But once the patient gets stabilized, once the blood pressure stabilizes, once urine output stabilizes, and the patient gets adequately filled, de-resuscitation or stopping IV fluids has not been seen as promptly as like a fluids. There is another point here related to the IV fluids is, if my patient is not responding to my fluids, how do I go about, and how do I know about my patient's fluid responsiveness? The devices which we talk about, dynamic parameters, we have actually dumped CVP onto the backyard. We are talking about even probably the dynamic indices, which needs either a arterial line with a monitor or a cardiac output monitor. But most of them are not available in many of our resource limited setting. Even in the tertiary care ICU, very few limited ICUs has access to them. And all these dynamic parameters have their own limitation, including your pulse pressure, stroke volume variations needs your patient to be sedated, paralyzed with a tidal volume of 8 ml challenge, all that is needed. So probably even in resource limited setting, we probably recommend about to use ultrasound. I think nowadays, at least in district headquarters and in the smaller units, most of us have access to ultrasound, and this is growing every year by year. So you yourself training sonology, training ultrasound is the way forward. So probably IVC collapsibility, looking at a 4-chamber view. If I have a collapsed IVC and probably empty heart, I keep on giving volume challenges till my capillary refill time is reached, or my patients probably windows of perfusion are maintained well. So that is probably the way forward in giving a volume. The simplest way I tell to many of the remote areas clinicians is, if you are pulse oximeter suggesting drop in saturation, probably from somewhere it is 98 to 99, now it is 94. So probably now you are wetting lungs. So your volume challenges has to be more judiciously monitored than previously. So oxygen saturation monitoring may be one way or to keep a watch on this if you do not even have a ultrasound availability on the bedside. So this is again the same what we actually saw in a surviving sepsis guideline. We don't use colloids. I have seen some of those clinicians still asking, debating about use of colloids. So we don't use colloids. We are using only crystalloids. And the only colloid which is probably nowadays used after a crystalloid load is albumin, but we don't have a robust evidence suggesting albumin in resource limited settings. So probably I will reserve albumin for those who have access, but our first choice or preferred fluid will be a balanced crystalloid solution, and that should be used as an initial challenges. Then we talked about our vasopressors. Epinephrine can be considered alternatively, and I will not go into the other details. And these are all the recommendation I was talking about. The surviving sepsis guidelines also talks about capillary refill time, which can be considered as an alternative to the yeah. And coming to the antimicrobial use, there is a discussion that the use or misuse of antibiotic in all these septic patient. If I have a patient who is septic and SOC, probably the antimicrobial administration has to be happen as early as 1 hour, not waiting for further information. But if I don't have any septic shock, so probably I can actually evaluate these patients as we actually saw, send for a rapid CAR test. And if you have an alternative diagnosis, probably you don't need such an empirical broad spectrum antimicrobials in many of them. So coming to those recent things which I told, we were waiting for a publication of some of our position statement from ISCCM, where I was fortunate to be a part of the same with Dr. Yes. So with our previous EC, we could actually come out with this, which is under the publication. So we will probably publish it next, but this is a pre-publication proofread, which suggests that QSOFA and MUOS are probably most feasible to be performed in Indian context, where we can actually pick up these patients who has a suspected infection, and my QSOFA is more than 2, probably that is the way forward. MUOS are probably the other feasible modalities where I can use. Coming to the biomarkers, we used procalcitonin a lot in many of our tertiary care private sectors, but again, we all understand procalcitonin has its own limitation, even though among all the markers, it is considered to be probably relatively better, but it's expensive, it's not available everywhere. So just relying on a procalcitonin as a biomarker to actually diagnose sepsis is probably not feasible in many of our Indian settings, and CRP can be a feasible marker, and we all understand either procalcitonin or CRP both can be used as an adjuvant to your clinical judgment, and we don't use both of them as a sole marker to diagnose or just to exclude a sepsis. They can be used actually to see the probably de-escalation or to see the severity, but not as a marker to diagnose. So alternatively, C-reactive proteins availability is more rampant or more common in many of the centers. So we all feel that that CRP should be available. As I told, blood cultures or any other cultures should be taken before antibiotic, but it should not delay the antimicrobial administration. And if it is not available, I think antimicrobial should be considered as early as possible, not delaying it for the cultures. Tropical infections, like as I said, the protozoals like malaria, dengue, or mellidosis, or scrub typhus, leptospirosis, many helminthic infestations all should be considered in the context of countries like us where they are not uncommon. So when there is a ICU bed is not available and we are waiting for it, probably a monitored ER room or a recovery room probably can be useful. At a minimum, the patient should be monitored for neurological status. As I said, the one window, peripheral perfusion is another window, and the other vitals should be monitored in these patients. Capillary refill time and the assessment of saturation and probably a continuous blood pressure or intermediate blood pressure and heart rate can be an alternative to those which cannot access to those invasive arterial lines, invasive cardiac output monitors. But these three, capillary refill time, intermediate blood pressure, continuous heart rate, and saturation, to actually target your maybe the volume challenges and elicates of volume, which can help in actually titrating. So we actually also talk about the balanced salt solution preferred as a ringer lactate or Hartmann's over the others. And we also talk about the dynamic parameters if are not available. Maybe we may consider about IVC use in them. Epinephrine can be used as an alternative vasopressors over norepinephrine or vasopressin. And empirical antiparasitic agent like antimalarials or helminthics can be considered in those situations where they have been considered as common or there's diagnosis is more possible. And the non-invasive ventilation should be considered in acute hypoxemic respiratory failure, or HFNC can be considered if it is available. And invasive ventilation is still a way away to actually get. Telecommunication, if available, should be used for the management of patients with the sepsis. So take home from my side, because we were all waiting for that to publish. So take home from my side is sepsis awareness is still not adequate, as we see like heart attack or a brain stroke. So the sepsis deaths are equally probably third leading cause after those probably modifiable diseases or metabolic diseases is more common. So we need to actually create awareness about sepsis. And what I realized is if a patient reaches to us in early part of sepsis, we do see a very good recovery without any organ dysfunction. But if a patient reaches to us in the later part of sepsis, septic shock, multi-organ failure, we realized that irrespective of whatever facility you have, irrespective of whatever support you do, including your maybe high-end renal replacement therapies or ECMO support, the outcome remains to be extremely poor. So early suspicion, early aggressive management, early probably source control, these are the key to save life. So I think not just public, also there's awareness in the medical practitioners, general practitioners, and healthcare professionals, including the nursing team, technical teams, and rural probably healthcare systems need to be created by probably all of us. The burden of sepsis is highest in low and middle income country, and 85% of the deaths happened due to sepsis happened in low and middle income countries. So we know this is killing us, so we need to work on it. And maybe QSOFA and MEOS with an infected patient should be a useful tool in our settings right now also. early resuscitation, early to start with IV fluids with ringer lactate, vasopressors if noradrenaline is not available, adrenaline, available appropriate antimicrobial, source control remains the first line of care, and these saved more lives than any super gadgets which I was talking about. And identifying a non-infectious cause. Suppose during the initial time, I may consider a multi-organ failure as an infection. But later, when I found out that this all cultures are negative, I had a non-infectious cause for all this. Then probably discontinuing antimicrobial is equally important in those settings. And at the end, probably individualizing each patient and looking at the resources available. As I said, whatever resources I have, utilize them appropriately. Suppose I don't have a very sophisticated intraarterial line and a cardiac output monitor, use a capillary refill time, saturation, and a sonography probe to actually titrate your fluid balance. And consider all of them and use your guidelines just to guide, not to decide what you should be doing in your patient. Probably guidelines or a position statement should just guide or give you some maybe information, but at the end of the day, you are at the patient's bedside. You should use your acumen to actually treat these patients. So I just try to give an overview. Probably we'll take comments from Dr. Yes, and then from there we'll take questions.
Thank you, Dr. Venkat. A very, very comprehensive talk. And most of it was very, very practical oriented, what we should be doing in our ICUs and what we should be following. You covered all the topics very well, starting from the resource limited setting, definition of sepsis, the day-to-day management of sepsis, sepsis mimics. One thing I want to still focus upon more is resource limited setting. When we talk about it, is not a particular physical constraint. We saw during COVID and other pandemics also, even high income countries can have a resource limited setting. It could be dependent on disease. If we have 15 patients of burns in a big hospital, even like a Yashoda Medicity, it could be a resource limited setting. So once we have a resource limited setting, we should be thinking different, and we should be putting our best resources forward and act like a very, very cohesive team, changing our roles and improving the outcomes as a team. Most of our settings in India, because of scarcity of critical care nurses, remains a very, very resource limited setting. And these are the challenges which most of the low middle income countries are still facing. So we should adapt to this resource limited settings and give solutions, as we did with these guidelines with the help of Dr. Venkat and many other ISCCM members under able leadership of Dr. Sheila. So we probably will need more of such solutions. The gap between the manpower requirement and what we actually have is widening day by day. We have more and more of ICUs opening up. More and more percentage of beds in hospitals are being made into ICU beds. Our roles are widening. We are looking out of the ICUs also. So probably we need more trained manpower, not only for sepsis, but also for other critical illnesses. We can go on to the questions, Dr. Venkat.
Yes, so I think I'll try to take some questions. The questions are, what is your personal experience on IV methylene blue for refractory shock after noradrenaline, vasopressin, and adrenaline? And I'm happy that methylene blue is not a expensive affair, so it can be available everywhere. So what is your experience, sir?
Can you please repeat the question?
Methylene blue. Can you hear me, sir?
Yeah, I can hear you.
So
methylene blue, again, is being used as a resuscitative agent. Once your routine vasopressors don't work, routine vasopressors mean norepinephrine and vasopressin. It is being generally used as a last line of agent. We have other agents also coming up which can be used on a compassionate ground, but the evidence for methylene blue is limited. Although in some settings, especially in refractory shock, more so in acute conditions, we have reversibility. Conditions like severe vasoplasia, which is drug-induced, some toxicities, again, like beta blocker or calcium channel blocker or corticosteroid insufficiencies. Methylene blue usage outcomes could be shade better. But if it is used as a last agent when everything is being failed and patient is in refractory shock, the outcomes are still very, very dismal.
So I think the
Another
same.
question I can read out.
Yes, sir. I think I just wanted to add, sir, the experience with methylene blue remained to the same. Like there are pockets of case reports not properly, I think, evaluated in a proper randomized control trial. And I got a call from Dr. Govil, sir, saying we are planning probably a proper trial in India where probably we can evaluate the role of methylene blue in this refractory shock once the adrenaline also is not helping in severe vasoplasic states. But yes, our experience remained the same. Like we used in few cases where IV methylene blue has been used in the refractory situations, and we could see some improvement in mean arterial pressure. But translating that into a mortality benefit is always a question which remained unanswered. We have seen a mixed kind of response in them. And but as you rightly pointed out by Dr. Yes, we use it as a last resort. At that time, you are already probably reached in point of no return. So that's the another problem which we say. Any doses you want to mention, Dr. Yes? There's a question.
Dosages still are very, very vague. And hello,
Yes, sir.
just a second, there is some issue. I'll come back. 1 second.
So I think we'll take some other questions. Sepsis, like a myocardial infarction, every minute counts is not been probably taken that seriously. That's our problem. That is where we have to actually probably make that awareness in from the critical care department or from the acute care department of your hospital that sepsis do kill patients. And sepsis has probably higher mortality than many of us, which we see with myocardial infarctions or with stroke. So it has to be given equal priority, and you should code sepsis and count every minute or hour. When to wean a stress dose of refractory shock? So see what we actually use steroids or the hydrocortisone of 200 mg in 24 hours infusion or in a divided doses. Once my patient's blood pressure map is maintained well in 48 to 72 hours, I discontinue. We don't taper. We discontinue those steroid doses. Any practice change from you, Dr. Yes?
Yeah. See, again, it depends upon the clinical context. Now, initial the choice was once your norepinephrine requirements are high, like less 20 mics. Then we used to start steroid dose. But now, even low dose of norepinephrine is again they are starting steroid. This is a practice changing thing which has happened in last year. The major question is when to stop. Generally, once your vasopressors are off, once it is stopped, after 12 to 24 hours, we have a look. And if the patient remains hemodynamically stable, we stop. But this is for conditions where we start it for septic shock. If there are other indications to continue steroids, long-term steroid use, we need to taper. If it has been started for a short term, only for shock, we can abruptly stop. No need to taper it off. So we can stop even after a single dose or once the dosage is off. One thing what we learned during COVID was how to immunomodulate our patients better, how to use steroids better. So the duration will not be just restricted to 5 to 7 days as it was in previous guidelines. It could vary depending on your requirement of vasopressors. And again, steroids uses a tightrope. You have to look at the side effects. If the hyperglycemia is bothersome and the blood pressure has stabilized, you probably can wean it off little early. If the patient is having gastric ulcer, GI bleed, and other major side effects, probably you can stop it early. Otherwise, 12 to 24 hours, since your vasopressor is off, you can then stop your steroids. The question was when to start methylene blue by Dr. Venkat. I'll take this question again. The question was answered by Dr. Venkat. Once your norepinephrine and vasopressin are not able to maintain a decent map, say of 65 to 70 for vast majority of conditions, we start methylene blue. But in some conditions like vasoplegic states of various causes, we can start it early. And there were some papers from Western Europe where they compared early use of methylene blue versus delayed methylene blue. Delayed means what we normally do in our practice. The outcomes were better when methylene blue was used early, especially in cardioplegic states and vasoplegic states. The usage was better. The dose is 1 to 2 milligram per kilogram, what we commonly use in our setups. Another question was about albumin, Dr. Venkat. Usage of albumin in septic shock as in dengue shock. This was the question. I will answer, then I'll come to you. Albumin can be used as a resuscitative colloid. When to use? When the blood pressure is critically low, say 45-50 map, and you want to raise the map to a decent level fast. Colloid, obviously, because it contains a larger amount of oncotic pressure, it will drive some crystalloids out of the interstitial fluid, it will raise the blood pressure faster. So whenever you want to raise your blood pressure faster and the blood pressure is critically low and you are requiring large amounts of crystalloid, that is the subset of condition where you can use albumin. The concentration is 4 to 5%, whatever is available, not 20% of albumin. The benefits of albumin is not only as a colloid, but also as an immunomodulator, improvement of the cytoskeleton of the capillaries, decreasing the capillary leakage in states of sepsis. So there are many benefits apart from this, but the indications are only for the subset of patient when the blood pressure is critically low and you want to raise it very, very fast. Otherwise, you are not going to use albumin as a resuscitative agent. But if you tend to use any colloid, the answer is only albumin now.
Yeah, so the interesting part is what do you do in dengue? So in a season of dengue, we do see that the patients who come to us in a critical phase, you may see a patient who is hypotensive, but he is maintaining his saturation, low perfusion. The moment you give a liter or two of crystalloids, they actually leak into the lung and they start desaturating very rapidly. So the question is, can we use any of the colloids? And the colloids we are nowadays not using as dextran or gelatins. They are not been any use. So the only colloid which is available is albumin. At this point of time, either up to date or WHO now are talking about dextran as a solution to use as a colloid in situations where you have a very bad capillary leak and you want some amount of colloid. But we all have experience with albumin where it is, if judiciously used, has been useful in dengue patients where your crystalloids are leaking badly and your patient needs some oncotic pressure. So probably we need a good study on that part, like what is the role of albumin in capillary refill syndromes of dengue, where you have a hypotension one side and third spacing on the other side. Any take on that, Dr. Yash? I think that is the emphasis there.
Yes, Dr. Venkat.
What is the role of albumin?
As you discussed, I also answered the same thing. When the blood pressure is critically low, that is the only condition where you want to raise it very, very fast. That is the only clinical indication which is evidence-based for use of albumin as a colloid in resuscitation. Otherwise, there is no other indication for resuscitation use of albumin. And when your albumin levels are low, you want to raise it. Those are all myths. We should not be following those principles. Even patient with CLD, they are in sepsis. Albumin is not the first line of agent. You have to use the regular crystalloids or colloids. The balanced colloids has been discussed. Balanced crystalloids has been discussed. There is another question, Dr. Venkat. I'll read it out. Dr. Anita has asked.
We also have a experience of a judicious use of albumin in a careful setting has helped our dengue patients who has not landed up into a capillary leak leading to further desaturation. So if you are an institution who can actually use and experiment and can do a study on that, albumin should be considered in this because we don't have any other colloids. Yes, sir. Sir, there are questions related to perfusion index starting for vasopressors. We are talking about pulsatile versus non-pulsatile ratio. If I have a device to use it, probably we know a cutoff of 1.4 as a perfusion index, below which we consider it's something wrong. So we improve this perfusion. And so questions related to gas, that streptococcal infection in obstetric deteriorating very rapidly. Can I take that question, sir?
Yes, please. Yes, Dr. Venkat.
Yeah. So for the audience, I just try to inform you now also these two group, the cocci of strepto and staphylo, causes toxic shock syndromes. If you have a obstetric patient or a patient who has a skin and soft tissue infection, and you see these patients rapidly deteriorating in your ICU, not responding to any form of vasopressor support, you should suspect a toxic shock syndrome in them. These bugs like Streptococcus, Staphylococcus can be pan sensitive. They can be sensitive to your penicillin, they can be sensitive to ampicillin, but they are highly virulent. Okay, they can kill your patient in no time, in 24 hours. Whatever you may do, they will not respond. So what do? We try to actually give a very aggressive source control in them, and we use high doses of antitoxin drugs like clindamycin or linezolid in them. And previously, there was some evidence suggesting immunoglobulins as a role, but that is fading away. So these are the bugs which are very notorious. They have a high mortality. So yes, they can still kill many patients even though they are pan sensitive. So you need to understand the difference between a resistance and a virulence. And these comes under a category of highly virulent organism, and these kill patients with a toxic shock syndrome, and that happens within less than 24 hours. So that point is well taken, that these gas organisms which actually can create a sepsis in obstetrics patient or any patient that matter with skin and soft tissue can kill patients. So I think dose of methylene blue you answered, sir.
Yeah, we answered.
So the other question is sepsis involvement in one organ dysfunction or more by any definition. Do you have any definition for one or more organs? Is it there any difference?
There is another question, Dr. Venkat. This question is from Dr. Just a second. Dr. Vinay. The role of early initiation of CRRT for source control to remove cytokines lactate in place of methylene blue. I'll take that question.
Yes.
Yeah. Okay. So CRRT has been proposed to cut off to immunomodulate various mediators of sepsis. But again, that is not a solution. The solution is to tackle the root cause, to tackle hypoperfusion, to improve the perfusion rather than only doing a reflex thing to remove these. Hyperlactatemia, lactic acidosis, again, CRT will remove it, but if unless you do a proper source control and you do a strategy of hemodynamic optimization, CRT is not going to work. Having said that, CRT fares better than other renal replacement therapies for hyperlactatemia and hypercytokinemia. But CRT and other renal replacement therapies or these extracorporeal therapies with designated filters have shown no benefit in improving outcomes in terms of survival advantage for sepsis. So still the practice does not have a major evidence of use of CRRT or extracorporeal therapies in sepsis for improving outcomes. But if you have a patient who has refractory shock, the blood pressure is critically low, and you have to use a renal replacement therapy, the answer would be CRRT rather than intermittent hemodialysis or SLED, because it will be tolerated better. So the quality of dialysis will be better, and the clearance of various toxins will be better. Dr. Venkat, you want to add something on this?
Yeah, I agree. I think we used this all form of filter from your endotoxin filters. We do also do an endotoxin assess. We also look at IL-6. We also look at some of the cytokines and the clinical syndrome at which we are. And we used all these filters length and breadth. the conclusion remains the same. Most of these filters help in stabilizing your hemodynamics. And the moment you discontinue these filters, you may see again there is a dip of your hemodynamics, and maybe the patient again deteriorates back. So these filters will have a role to bridge the gap when your conventional methods are not helping and you have all the facilities available at you. So my take will be the standard of care remains the same. We don't have a robust evidence supporting, suggesting, recommending these filters as a standard of care. But yes, this can be used if you have a system or you have access to evaluating this endotoxin levels or a cytokine levels, and you categorize them in which part of sepsis you are and which filter can be used. Is it a endotoxin removal filter or a cytokine removal filter? What is your problem? And you already are in the need of a CRRT, as already been mentioned. So this only adds again only extra filter to that. But again, we have seen there is a mixed response, and if you actually stop the filtration, you also see these patients may come back with the hypotension and all, and maybe deteriorating again. So the cycles and the number of attempts need to be again reconsidered. So most of these filters has their gray areas at this point of time. They are still experimental. We still keep them open only for those facilities which can experiment these when the standard of care is not responsive. Dr. Yash, there is a question related to lactic acidosis, which is very interesting. And I think most of our clinicians do probably focus on it. That is lactic acidosis treated with renal replacement therapy or a CRRT. Do you want to take that question?
Yeah. Again, see, you have to tackle the cause. You have to tackle the cause of lactic acidosis. Just removing the lactate will not help unless you tackle the cause of increased lactates. Having said that, CRT is better because production of lactate is continuous. So clearance of lactate with CRT will be better. Another important thing is if we remove it with an extracorporeal circuit, you will never know how is the patient responding to your fluid resuscitation or to your hemodynamic optimization. And lactic acidosis per se will not cause any hemodynamic compromise. Still, if the patient is having metabolic acidosis, bicarbonate is low, obviously you have to tackle that. But only for clearance of lactate renal replacement therapy in sepsis or otherwise has limited evidence, and that does not improve the outcome. Dr. Venkat.
Yeah, I think this is an ongoing discussion among our nephrology colleagues, and we as Dr. Just already explained. CRRT removes lactate, CRRT clears lactate, but what is commonly seen in septic patient with a high burden of lactate, in spite of your active clearance from CRRT, your lactates doesn't drop. The reason for that is if your lactate production is very high and your liver is not really metabolizing your lactate, your CRRT can just remove some 5% or 10% of it. So 98% is still there in the burden. So CRRT's capacity to clear the lactate, if the production is high, is probably of no role in clearing lactates. It is only that, as Dr. Yash said, you have to stop lactate production. You have to make your liver to function well so that the lactate get cleared. CRRT cannot be the answer. Probably CRRT is a modality where you support your renal system and also help in some amount of clearing the lactates. And the percentage when your lactates are extremely high in production, CRRT cannot match it, and CRRT cannot improve your lactate clearance in that way, because there is a very gross disproportion between your lactate production and CRRT, what it can clear. So there is another interesting question like the tocilizumab, IVIG, and the role of them in your experience with the cytokine storm, if at all you have.
I will take that question.
Yes.
Okay. First of all, the cytokine storm is a misnomer. We understood it in sepsis. What we should be calling it, is hypercytokinemia. So cytokine storm term in sepsis has been abandoned. Which one to use? None of them has any evidence for sepsis per se. So if you identify hypercytokinemia, again, look at your source control, right antibiotics, volume optimization, hemodynamic optimization, oxygenation optimization, and also look at thromboimmunomodulation. If the patient is not thromboimmunomodulated, the hypercytokine will be continuously fueled. So these are the interventions which can work with hypercytokinemia, and none of the drug in sepsis has shown any benefit till date for hypercytokinemia.
There are questions again, role of steroids in severe pneumonia with shock. Role of steroids in pneumonia, severe pneumonia. Sir, you unmuted yourself, sir.
Severe pneumonia,
Please.
there is some role and people have started using it. The role is more in viral pneumonias rather than bacterial pneumonias, but severe community acquired pneumonia, as in septic shock, people have started using steroids early rather than late. If there is hypoxia, if there is no hypoxia, can still wait.
Yes, I agree. I think we all started using steroids in severe community acquired pneumonia. We have some evidences in supporting that. Probably I will be more careful in influenza pneumonia. In influenza pneumonia, we are still not very comfortable using in steroids because of those influenza pneumonia. We have seen the negative collateral harm than benefits. But rest all, if I have a severe community acquired pneumonia coming to the ICU in intensive care unit, if I don't have any contraindication, probably I may consider using a stress dose of steroids in most of them. And septic shock, I think it remained to be the same. If I have a community acquired pneumonia or any other sepsis, I have a septic shock with requiring vasopressors, not maintaining mean arterial pressure, probably I'll continue to use them. Sir, again, I think you answered all the rest of the questions like methylene blue dose 1 to 2 milligrams at this point of time. Yes, we don't know the accurate dose, but we all use same 1 to 2 milligrams per kilogram of methylene blue in a start dose in them. Any other questions, sir? Anything, sir? Anything to wind up the session? I think we had an interesting question answer session. Anything to wind up? What are the takes in resource limited setting? You actually gave a your perspective of even so-called high income countries with a lot of resources can get into strain, which we have seen during COVID with resource limitation. In India, with the current situation, what are the key messages you want to give to all the clinicians? We all work in a very diverse kind of clinical setups with a lot of disparity in our availability of gadgets and facilities, paying capacities, and most of our patients have their challenges in even affording the healthcare systems. So what will be your key 4 or 5 points to all of us?
Thank you, Dr. Venkat, for asking that. So the basic principles for sepsis or for any critical illness is keep it simple. Have a minimalistic approach. Use interventions, monitoring, or treatment strategies which have larger evidence. Every intervention you do a risk-benefit analysis. If the benefit is more, the evidence is more, you use it. If the evidence is less, do not use a redundant therapy and add burden to the financial status of the patient and the emotional burden also. At the same time, the diagnosis of sepsis is most important. You have to diagnose it early. You have to train your emergency physicians and the ward hospitalists and medical officers to diagnose early. Sepsis could present in any form. It's a very, very heterogeneous disease. The presentations and dynamics of sepsis is also very, very heterogeneous. So we need to individualize and personalize treatment. Most of the adjuvant therapies, including the extracorporeal therapies for sepsis, still do not have any major body of evidence. So what works is the surviving sepsis guidelines, most of the interventions, and we need to have a individualized and personalized approach for sepsis so that we can improve outcomes. Thank you, Dr. Venkat.
I think very well summarized, sir. You actually put everything into one year. If you do the basics right, do the standard of care right. If the patient is an early part of sepsis, 90% of your patients do better and they get better. The basic right are the same. Identify a patient early, maintain the perfusion, maintain the oxygenation, do a source control early, use an appropriate antimicrobial early. So these are the basic things which remain. The other sophisticated, probably controversial things which we are talking about, like using any filters, using any markers, using any procalcitonin, none of them has shown right now any robust evidence suggesting their benefits. So they have to be come under experimental basis or adjuvant or maybe as a rescue therapist to them. So the basics, right? And you use your gadget, individualize your patient, individual your local need. The last two questions which I will take, Dr. Yash, are: is there any role of ECMO in septic patient? Sepsis is, as some of our friend has commented, is a severe vasoplegic state. Okay, and we have realized that if I have a severe vasoplegia, there is a vasoparesis and there is no tone at all. Probably even a VA ECMO may not help in most of them, and we don't have any much great evidence in the outcomes of VA ECMOs in them. But if I have a patient with sepsis with myocardial dysfunction, I have a septic cardiomyopathy, and that is contributing a good amount of it, then probably early initiating of a VA ECMO, treating my source probably has a role to play. So all septic patients, look for your cardiac dysfunction. If I have a severe cardiac dysfunction and that is contributing a good part of my shock because of myocarditis, because of septic cardiomyopathy, because of stress cardiomyopathy, then probably considering a VA ECMO has shown to be beneficial, and it is comes from a pediatric population. In most of the pediatric population, this has been what experimented, or this has been tried, and this has shown to be successful. So if I have a patient with septic shock and I have a cardiac dysfunction, I may consider them if I have still believe that there is a reversibility. There is another question related to sepsis is a vasoplegic state, not a capillary leak phenomenon. See, in dengue, we see both of them together. We see a vasoplegic state. Also, we see a capillary leak, both of them together. So if I don't have a capillary leak and I have a severe vasoplegia, initially giving some volume challenges or volume probably resuscitation, clipping and monitoring, adding to that a vasopressor may help. But if I have a very severe capillary leak, like what we see in critical phase of dengue, even a half a liter to a liter, in my experience, has shown to be very catastrophic. It just sinks your patient like this. If my ER physician or my colleague in the periphery has given a liter or two, that patient's hypotension further worsens, and that patient's gone into hypoxia. They need an intubation. During the intubation, patient gets a cardiac arrest and succumbs, or the pH goes to 6.9 and you get that vicious cycle. Instead of that, if I have a patient with severe shock, with severe capillary leak, probably I will be careful in monitoring them, giving a vasopressor, titrating my volume with a colloid, and slowly probably using a HFNC, keeping them prepared for them, because most of these patients also have a severe myocarditis and cardiomyopathy in them. So these are the patients where probably they will have a very less tolerance to crystalloid boluses in particularly severe dengue with severe capillary leak. Have you seen that happening, Dr. Yaski? Patients with severe dengue with hypotension, the moment you give a couple of liters of fluid as a standard of teaching, you see them hypoxic, you drop their pressure further, they get respiratory arrest, you intubate them, you land up in 6.9 pH, it gets into a vicious cycle.
That is very, very true, especially for dengue in hypercytokynemic phase. And most of the dengue patients in the last cycle deteriorated because of ARDS and related complications. And as the question comes, we have to categorize what type, is it a vasoplegic or non-vasoplegic, as we used to call it as a cold shock or a warm shock. And accordingly, if it is a cold shock, the therapies have to be different. If it is a warm shock, we need to have an ionotrop. It is a cold shock, we need to have a vasopressor agent. Same applies to flutes also. If it is a vasoplegia, some flute can work, but if it is a inotropic issue, a cold shock, then we have to be very, very judicious. And we need to give very, very small aliquots of fluid rather than giving large
True.
boluses of fluid. Even if the patient is fluid responsive, in such diseases, we have to be very, very careful.
Agreed. What is the antibiotic ladder to actually discontinue if my cultures are negative? That was one question. I think that we'll take as a last question. Antibiotic discontinues or a de-escalation ladder if your cultures are negative.
No. See, cultures 40% of the time would be negative.
True.
Because of various reasons. I will not go into those reasons.
Hmm.
So if your patient is improving, you find a non-infective cause of shock or the disease is not an infective etiology, you can stop. But if the cultures are negative and the etiology is infectious, you have to continue with the antibiotics. If the patient is improving with the same antibiotic combination, if the patient is not improving, your cultures are negative, then you might need to escalate also, probably.
Yes.
So depends on the context what we
Yes.
are talking about.
We are talking about the criticality and the state and condition of the patient. If my patient is sick and is improving on set of antibiotic and my cultures are negative, I have a infective cause, but I'm not able to localize my organism or source, probably I will not discontinue or stop antimicrobial. I'll continue those antimicrobial at this point of time. If my patient recovered and I found a non-infective source, probably I will discontinue on that system. So it is all about the seriousness of the patient, because it cannot be a standard flat line, because cultures are not 100% sensitive. As very rightly pointed out, in community acquired pneumonia, the blood culture positive rate is 20%. In CSF, it may be the same. So the blood culture positive rate, even you take 3 sets of culture, maybe 60–70%. So, and as you said, if the patient is already received antibiotic, it may be much lower than that. So in this context, probably we may not make a probably flat statement saying we will discontinue antibiotic when my patient has a infective etiology on your clinical ground and responding to your antibiotics. Culture alone cannot actually
And
take.
another.
Yes.
And another thing is, the clinical cultures depend on the site of infection. You might have a negative culture because the site of infection is something else. You are expecting it to be bloodstream infection, but the site of infection is pneumonia or a urinary tract infection, and there is no bloodstream infection. So there are many variables. Having said that, you have to send the clinically relevant cultures, and if it is positive, probably you have to treat it accordingly. If it is negative, you have to take with a pinch of salt. If the etiology is infective, you have to continue with the antibiotics. If the patient is deteriorating despite being on those antibiotics, you might need to escalate also in a culture negative scenario.
And probably broaden your coverage, which you are missing. You look at your tropical fevers, where you are missing malaria, you are missing lepto, you are missing scrub, whether you need to add azithromycin. Escalation is not always about cholesterol, not always about polymyxins or echinocandins. It is about from community. If a patient comes, look at them. If you have an immunocompromised host, look at a fungus possibility. And probably only role, if I look at, is procalcitonin is discontinuing or de-escalating. If I have a good negative predictive value, if my procalcitonin negative, my cultures are negative, my patient has some non-infectious causes, probably I'll use procalcitonin as a place there. Sir.
Yeah, very rightly said. The role of procalcitonin is only in de-escalation. Many people misuse it for escalation, for thinking that it is an MDR infection. That is not the right way. The role is only for de-escalation.
I think we had an interesting discussion, a good number of participation, and I thank Dr. Yash for his time and his presence and his interaction, his sharing knowledge. It's always a pleasure to interact with you, Dr. Yash. Thank you very much to be a part of this session. I hope all the participants actually enjoyed the session. We continue to do this academic program. Thank you all for joining us. I conclude the session. Thank you.
Thank you, Dr. Venkat. It was a pleasure hearing to you, and I expect everyone has gathered a lot of information, especially relevant to our context. And we all have learned something from each other.
We
Thank you.
hope that position statements may be published, and that will give us a lot of insight into it.
Thank you.
Thank you.
Bye-bye.